Yeah, hi, I'm Kim Jenkins. I'm a psychiatrist and I'm the current president of the Royal Australian and New Zealand College of Psychiatrists.
Now, you've just spoken about the college's role and development of equally well type strategies. What's your approach? What have you done?
Well, as a college, we recognise that we should play a much larger role in mental health advocacy, and we decided to embark on a very large advocacy campaign, and our first advocacy campaign was about physical health of the seriously mentally ill. So this was a long time in the coming, and a lot of planning went into this advocacy campaign, but we actually produced 4 major documents looking at the physical health problems experienced by people with serious mental illness, what was available, what was the barriers to care, how we should be helping people, and probably one of the most influential of those documents was the one that addressed the financial costs of serious mental illness and physical health problems. Why I say that was one of the most important ones, because when you're doing a big advocacy campaign, you want to influence key decision makers and governments and policy makers, and if you can put a dollar sign around how much something costs, you've got their ear.
How much is what you've done also a campaign to members of the profession? What kinds of clinical change do we need to see to address these things?
Very much this was for members of our own profession as well, because an important arm of the advocacy campaign was to educate our own members, and educate psychiatrists and trainees, and make sure that when we're involved in providing mental health care, that physical health care gets addressed as well. So we've gone on to develop a whole lot of resources for clinicians working in this field. In the training of our psychiatrists, we've made sure that physical health is an important component of every trainee psychiatrist training program. We have in-training assessments about physical health as well, and physical health comes up in our summative exams at the end of people's training, just to make sure that every psychiatrist that gets their fellowship in Australia and New Zealand is across the physical health issues and the physical health needs of their patients.
And what would that look like? What would be 2 things that they might do that otherwise that they wouldn't have thought was actually in their area of work?
Oh, I don't know that I can condense that down to just 2 things, but we have to be very aware of the side effects of the medications that we prescribe. And everybody working in mental health, and particularly in psychiatry these days, is very aware of metabolic side effects of medications. We need to be monitoring blood glucose, we need to be monitoring weight, we need to be keeping an eye on what's happening with people's cardiac function. And so there are very important things to look at from side effects of medication, and to make sure that we can minimise those and avoid them if at all possible. We need to be advocating for people to have other health checks and look after the rest of their health as well. And one of my personal beliefs is advocating for people to exercise, and getting a regular exercise routine going is one of the very important things. So apart from medications and general health care, one important thing that we have to address is things like working with our colleagues and increased communication with others involved in a patient's healthcare. Good communication channels with GPs and physicians and the nursing staff that look after patients as well, to address their physical health cares. We've developed an audit tool for psychiatrists, which is a sort of checklist that people can run past their own clinical practice and make sure that they're covering all the bases for physical health care as well as mental health care.
It's interesting, particularly that you raised about medications, and that's a big focus, and it's come up a lot here. In terms of that whole thing of medicine being about doing no harm, and a lot of the people here with lived experience have talked about the harm caused by medication, dosage and the particular types, but also about compulsory treatment, and really a failure in many cases for the system to be able to support things like talking therapy rather than medication. What are you doing with that? What are your concerns, and do you sort of hear what they're saying?
Oh, we hear what's being said most definitely on that front. there's about, I think there's about 3 questions in what you
Yes.
just said packed in there. I think whenever considering medication, it's got to be, as far as possible, a joint decision. With any intervention in medicine, particularly medications, it's the patient, the person receiving the medication, needs to be fully informed and be aware of the pros and the cons, the benefits, the side effects, and balancing up what is right for that particular person at that point in time.
So we're just resuming our interview now with Dr. Kim Jenkins. We had to move out of the main plenary. So I wanted to ask you about a range of issues around medication, compulsory treatment, and why talking therapy is not an option in so many public hospital settings instead of medication.
Right, this is going to test my memory. 3 issues in one question. Supported decision making, I think, should be at the centre of what we do as psychiatrists. We're there to work with our patients. It's a partnership. With regard to medications, before prescribing any medication and before taking any medication as a patient, you want to be informed of benefits, side effects, why this is being prescribed, have a good understanding of the pros and the cons so that you can weigh it all up yourself and make that decision as to whether this is right for you at this point in time. In many mental health conditions, medications are not the mainstay of treatment. They're very important, but we can't underestimate the need for the talking therapies as well. Whether it be structured talking therapies such as CBT, that is really important as first-line treatment for anxiety disorders, or whether it's more formal psychodynamic psychotherapy, supported psychotherapy, interpersonal psychotherapy, and the talking therapies and listening to people, hearing their stories, helping them work through things that can sometimes move over into counselling rather than pure psychotherapy, I think is really important part of patient-centred care. Sadly, as psychiatrists, in the structures in which we work, there's often not enough time for those therapies, particularly in public practice, where everything needs to be evidence-based and worked out, and the cost benefits of the treatments that we prescribe or we offer to people. There's less of an evidence base in the way we usually think of in medicine for psychotherapeutic treatments. But I personally think it's a really important part of treatment.
But is that a big plank in your advocacy to make that become more a focus in public health?
I think it's a big point of advocacy for psychiatrists and those working in mental health in general. It hasn't been a formal part of the advocacy campaign that we ran on the physical health of people with mental illness. Our advocacy around that has been much more around recognition and practical ways of helping people get good physical health care as well. So that, yes, it's an important area to advocate from, but it hasn't actually been part of the big advocacy campaign that I was talking about earlier. But there does need to be time for discussion of any medications, discussion of lifestyle, and how people do look after their physical health, because physical health and mental health can, in my mind, can't be separated.
And compulsory treatment orders, did they fit also, do you think, in that whole area of the physical health impacts as well as mental health impacts?
That's a really difficult one, and compulsory treatment and compulsory treatment orders is a very fraught, controversial area. There's much work being done in that area, and every time a Mental Health Act is reviewed, compulsory treatment and what is meant by compulsory treatment and when we do treat people involuntarily is reconsidered. And worldwide there's a move to look at mental health acts and make mental health acts much more patient-centred and informed. And I think when we've got supported decision-making and things, that is a real point of contention with involuntary treatment. Competency and capacity-based treatments are far more important than involuntary treatment. I don't know that we'll get ever be at a stage where involuntary treatment isn't needed, but it should not be a first-line treatment, and it should not be something that's undertaken lightly. We're all very aware that in treating somebody involuntarily, you're basically taking away important human rights here, and it is an infringement on people's human rights. But at times when some people are very unwell and they've lost capacity to make decisions for themselves, there may be, in some instances, a need for involuntary treatment because people also have a right to treatment that will make them better and that will restore their capacity for them. But in the past, I think there may be instances when involuntary treatment has been used too frequently, and in 2019 we need to be much more judicious about the use of involuntary treatment in general.
And just one final question. You gave a very personal experience, and that related to diagnostic overshadowing.
Oh, yes.
Could you first define that for us, and then to talk about what happened?
Yeah, I think with diagnostic overshadowing, it's actually one of my favourite terms in thinking about the interaction of physical health and mental health. And what we tend to do is, if you have a patient who is known to have mental illness, who presents to a physical health doctor, it's very easy to dismiss maybe some of the validity of some of their physical health problems because they have a mental health problem. It's also very easy to be blinded and only see the mental health issues and not see the underlying physical health issues. And this is something that was brought home to me in a very personal way with the instance of my mother, who has had various mental health problems throughout her life. And shortly after my father had died, her mood seemed to be very flat. She wasn't able to enjoy anything. She wasn't smiling when the rest of the family were laughing, and we put it all down to grief and her dipping back down into another episode of depression, until I took her along to a local GP, who, as soon as we walked in the room, said, "But your mum's got Parkinson's disease." And here am I, a psychiatrist, seeing it through my lens of only looking at depression and mental illness, completely missing the fact that my own mum had Parkinson's disease. Now, what a bit of huge diagnostic overshadowing was that one.
Thank you very much, Kim.